Hello, everyone. I hope that you all are doing fine and enjoying Melbourne's cold weather. Okay, so it's very, very cold these days in Melbourne. And yeah, okay, so we will start with today's pages that we need to do, which is we will start from page number 100, and we will start from this topic: human papilloma virus related oral lesions. So this is the HPV infection, which is caused by the viruses, can cause a wide range of oral mucosal lesions. The virus is usually transmitted by direct contact with the lesion, so it is an infectious. Okay, so it can be transmitted by direct contact with the lesion, and squamous papilloma is the most common oral HPV lesion. So there are certain type of lesions that the HPV virus can cause, and squamous papilloma is one of these, and that is most common, appearing as a protruding growth with a small finger-like projection, just like this one. This is the classical presentation of squamous papilloma caused by HPV virus. Sexually transmitted HPV infections can cause oral HPV lesions called condyloma acuminata. Verruca vulgaris, the common rot, is also caused by HPV infection and may present in the oral cavity. So these are certain type of lesions that could be present in the oral cavity and caused by HPV virus. Okay, both condyloma acuminata and verruca vulgaris can be clinically similar to squamous papilloma. Oncogenic types of HPV are now recognized. So these HPV virus can also lead to cancer. So there are some types that are recognized now as a cause of some squamous cell carcinomas, particularly of the posterior tongue, tonsillar region, and oropharynx. These appears to be a distinct entity separate to the oral cancer associated with alcohol and tobacco use. So generally that we read in few back pages that the risk factors for the oral cancer or the oral squamous cell carcinoma is the alcohol and tobacco use. Okay, so but they also stated that certain types of HPV could also lead to this cancer, and this presentation is different than the classical presentation of the oral squamous cell carcinoma caused by alcohol and tobacco use. Then refer patients with suspected HPV lesions to an appropriate specialist for biopsy and management. That's the reason we need to refer the patient for the biopsy and management. And who would perform the biopsy? The treating specialist would perform the biopsy. But in rural or remote areas where there would be a delay, then you can seek expert opinion on that. And the type a punch biopsy is not appropriate. So you need to either take incisional or excisional biopsy, or the like whatever useful biopsy types would be beneficial for that lesion. You can try that. Okay, so the other lesion is the oral lichen planus. This is uncommon. Idiopathic means their cause is not known, but they are immune mediated conditions that can affect. So they generally affect skin, hair, nails, oral, and genital mucosa. For management of lichen planus not occurring in the mouth, see lichen planus in ETG. So it is a systemic condition, not only an oral condition, the lichen planus. But this lichen planus can also cause the lesion in the oral cavity, which are mainly present on the buccal mucosa. So there are two cases that you can read with this topic, which one case is about lichenoid reaction and other case is about lichen planus. So you can read in Odell and you will find much clarity. Oral lichen planus typically occurs on the buccal mucosa, tongue, and gingiva. So there are certain types of lichen planus. Okay, so in the non-erosive form of disease, the lesion consists of a characteristic. It has characteristic reticular pattern of white striations or plaques. Okay, just like this one. So this is its characteristic appearance with the white striations. Okay, but there is other type which is the erosive lichen planus. In that case, it would present as erythematosus, ulcerated, eroded area of mucosa, which are often painful. So if there is a erosion, so it would be painful. Symptoms include stinging or burning, especially with the spicy or acidic food. Oral lichen planus is associated with an increased risk of oral squamous cell carcinoma. So, if in any patient there is an oral lichen planus, it could also be associated with the increased risk of oral squamous cell carcinoma. So, what you will do if you are suspecting any squamous cell carcinoma is you will refer the patient with the suspected oral lichen planus to a specialist for biopsy, definitive diagnosis, and management. Differential diagnosis should include oral lichenoid reaction, which the lichenoid reaction and lichen planus are a bit similar, but this thing happens generally, I'm sorry. In relation to any like amalgam restoration or any medicine. So but they are quite similar to each other. And if lichen planus occurs on the gingival tissues, management include improving oral hygiene and periodontal health. Patients with oral lichen planus requiring ongoing review by oral medicine specialists because of the chronic nature of the condition and the potential for malignant transformation. So if in your patient there is oral lichen planus, then he needs to be reviewed continuously by an oral medicine specialist because it has increased risk of transformation into malignancy. If biopsy proven oral lichen planus becomes symptomatic, treat with betamethasone dipropionate 0.05% cream or ointment topically to the lesion twice daily after meal until symptoms resolve. Okay, so this is an corticosteroid cream that you give to your patient when their oral lichen planus is becoming symptomatic. What is the meaning of symptomatic is, so there is pain or there is any symptoms from that, so that you can prescribe this cream to them and ask them to apply 2 times a day until symptoms resolve. Advise patients to stop using topical corticosteroids once symptoms have resolved. Okay, if the patient's symptoms have not improved even after 3 weeks of topical corticosteroid, then the symptom changes or the appearance or texture of the lesion changes. Advise patients to return to their treating specialist. Okay, so in this topic, what you need to learn is what is the lichen planus. It is an uncommon idiopathic immune related condition which does affect systemically, and in oral cavity it does occur mainly on buccal mucosa, tongue, and gingiva. It has two form. In non-erosive form it has the characteristic reticular pattern, and in the erosive form it has the erythematous, ulcerated, or eroded area, and that is often painful and symptomatic, and that can also increase the risk. Oral lichen planus is also associated with an increased risk of cancer. What you need to do is refer the patient for continue reviews, follow-ups, and biopsies. Okay, but if in your patient the biopsy proven oral lichen planus becomes symptomatic, okay, so then you can prescribe them this ointment or cream for some for 1 week or something, and if still their symptom does not resolve within 3 weeks, then you need to refer them again to the treating specialist. Okay. Then oral lichenoid lesions are similar in appearance to the idiopathic oral lichen planus. So this is lichenoid and this is lichen planus. So here this lichenoid reaction has happened to as a contact hypersensitivity because there was an amalgam restoration in regards to that. So in contact with that amalgam restoration as a hypersensitivity, this lichenoid lesion has occurred. So lichenoid mucosal reactions can be caused by, so there are certain causes which might lead to lichenoid reaction. First is, which is the most common, and which is the contact hypersensitivity to dental restoration, and it is mainly seen with the amalgam. Okay, then hypersensitivity relations to drug, particularly which drugs can lead to hypersensitivity. Drugs that lower blood pressure, which are the beta blockers, angiotensin converting enzyme inhibitors, diuretics. And then NSAIDs, then drugs that treat thyroid disorders. So you just need to remember, like, the low drugs that lower the blood pressure, NSAIDs, and thyroid disorder. Then, which medical condition can make you more prone to get lichenoid reaction is if you have hepatitis C infection, particularly in patients with the human leukocyte antigen HLA-DR6 allele. Okay, and if they have thyroid disorder or chronic graft versus host disease. So this thing, thyroid one, you can remember if the patient has thyroid disorder, then he must be taking the thyroid drugs, right? So in both the cases, the chances of lichenoid reaction increases. Then refer the patient with the suspected oral lichenoid lesion to an appropriate specialist for a definitive diagnosis and management. So you just need to make sure that this is only a lichenoid reaction. So for that, you need to refer your patient to the specialist. In the case of contact hypersensitivity to an amalgam filling, replacement of the implicated amalgam filling may result in partial or full resolution of the lesion. However, removal of all amalgam filling is not required. So, as you know that this is one of the scenario as well in which the female asks you that she has got allergy, and she wants you to remove all her amalgam filling because she is afraid, uh, as she has the nickel allergy, so that could lead to more allergic reactions in her mouth. But here they state if there is any contact hypersensitivity in regards to this restoration, so we only need to remove this restoration. Even though any other amalgam restoration are present in patient's mouth, you do not need to touch them unless those restorations does require removal, repair, or maintenance. That is a different thing, but only on behalf of contact hypersensitivity, you do not have to remove all the similar restorations from patient's mouth. Then geographic tongue, it is also known as erythema migrans. It is a benign condition and it is affecting up to 5% of the population. It manifests as a migratory red lesion. Migratory red lesion because it is continuously changing its size, its site. Okay, and it is red in color, and usually it involves the dorsal surface of the tongue, but sometimes it also extends to the floor of the mouth and buccal mucosa. The red patches have a central atrophic and depapillated zone, which is the most common presentation. Is surrounded by elevated white or cream margin, just like this. So there is red color zone and surrounded by white color, um, surra- um sorry, why elevated white or cream margins. Occasionally, the central red patch is sensitive, but it is not painful. If pain or burning is present, investigate for other causes or seek expert advice. Okay, then the cause of geographic tongue is unknown, but there may be a family history of the condition. Some patients have atopic allergies, so it could also happen due to the allergic reaction or can relate to the lesion to particular food or any stress. So, what are the reasons that could lead to geographic tongue? family history, any atopic allergies, any particular food, or stress. Histologically, the lesions are psoriasiform, but geographic tongue is not related to a specific condition. And the management of the geographic tongue is not required beyond correct diagnosis and reassurance. But if there is any red flag feature that you notice, then refer to the appropriate specialist. So you just need to remember these red flag features by heart. Which are these? Three types of ulcer. Ulcer having more staying for more than 2 weeks, ulcer that is reoccurring, non-traumatic ulcer in children. Then two are pigmented lesions, pigmented lesion, and the other one is the red, white, or mixed lesion with all the signs of indicating cancer. And the other things are paresthesia, then persistent discomfort, lumps or any swelling, or salivary gland swellings, then any allergy, adverse reaction, mainly oral lichenoid lesions, then dry mouth. There is two points for the dry mouth. First point is that is not getting treated even by doing any other strategy, or dry mouth that is caused by systemic disease. Then there are two other systemic problems. Like first is suspected oral manifestations of systemic disease and lesions occurring in immunocompromised patients. Okay, so just try to keep in mind all these points of red flag features. That is very, very important. Okay, then amalgam tattoo. So this is the amalgam tattoo. Amalgam tattoo are a common cause of exogenous oral discoloration. They result from the iatrogenic mucosal implantation of amalgam particles during the course of a dental procedure. So iatrogenic means caused by dentist. So by mistake, when you were putting amalgam filling, that time it might happen that it got any contact with the mucosa and it could lead to this discoloration. They are usually small, macular, and blue gray to black in color. Amalgam tattoos are usually found in close proximity to amalgam restored teeth or where such teeth were previously present. Amalgam tattoos are benign and do not require any treatment beyond correct diagnosis. To confirm the diagnosis, metallic amalgam particles may be evident. When you will take the X-ray of that area, you can see a metallic amalgam particle there. If the diagnosis is not confirmed, or if any red flag features of the oral mucosas are present, then refer them to the appropriate specialist. Okay, so what we have read so far. So if there is any suspicion of oral cancer, just straight away refer them to the specialist. If leukoplakia, referring. Erythroplakia, referral. And in this case, it is normal referral, and in this case, it's urgent referral. Human papilloma virus, referral to the specialist. Oral lichen planus, referral, because all of them, even the oral lichenoid lesions, they can increase the risk of getting oral cancer. So refer them to get the biopsy done and for completing the investigation. But for geographic tongue, you can still treat it, and because there is no management of that, you just need a reassurance. And but if there is any red flag features, then you need to refer. Same for amalgam tattoo. You can just, there is no treatment required for this one, but if there is any red flag feature, then you need to refer the patient. Then the hairy tongue. Hairy tongue occurs when excessively long and hyperkeratinized filiform papillas of the tongue become stained by an accumulation of epithelial cells, exogenous material, or chromogenic microorganisms. So you all know that the tongue contains of many types of papillas. So this is filiform papillas are most, they are smallest one and they are many in number. So when they get hyperkeratinized and there is accumulation of epithelial cells, material, and chromogenic bacteria on top of them, that is called as hairy tongue. It is usually black, but maybe any other color, and can occur with the use of chlorhexidine mouthwash because that also has the property of staining after a course of antibiotics also, or in a patient who have limited oral intake. Okay, because you all know that whenever we are eating, or whenever we are using our tissues or these papillas, so they are continuously deforming and new are forming. But if we do not use them, such as in mainly in the cases of the patient who are on percutaneous endoscopic feeding, like they are feeding through that tube, so they are not using their oral tongue or oral cavity. So in those patients mainly these papillas get hyperkeratinized and they can lead to hairy tongue. If any red flag features of oral mucosal disease are present, then refer them to the specialist. And the management would be involving identifying and addressing the cause, why it has occurred, like whether the endoscopic thing is there, or what's the cause of this. You need to find the cause. And then other strategies include improving oral hygiene of the patient, brushing the tongue gently because there is some debris which is present, right? So you need to improve the oral hygiene, brushing the tongue gently with a toothbrush, and using sodium bicarbonate mouthwash. Okay, so this is a different type of mouthwash that we have not studied so far in the previous pages. So sodium bicarbonate mouthwash is used in hairy tongue. Okay, and this mouthwash can be made by adding a half a teaspoon of sodium bicarbonate powder to a glass of warm water. The mouthwash can be rinsed in the mouth on waking at any time during the day. And this is the picture of hairy tongue. The filiform papilla gets hyperkeratinized. Okay, then traumatic oral ulcer. There is very good scenario and very important question that comes on this topic, which is the traumatic oral cancer, where the patient gives you the history of traumatic oral ulcer, but it is present since more than 2 weeks or more than 3 weeks. So if the ulcer is present on the lateral border of the tongue, okay. So here just you need to apply the simple concept that you have learned so far. So whenever I am saying this line, try to find the red flag features. If I am saying I am having any ulcer on my tongue and it's present on the lateral border of the tongue and it is present since more than a month. Okay, but it was caused by any broken filling or any broken tooth in that area. I'm giving you the history that this ulcer is caused by this. So would just let me know what you think, and would you just trim that area or smoothen that area and leave it, or you would refer the patient, you would smoothen that area and on the same appointment you would refer the patient to the specialist, because there is red flag features. Which are the red flag features? First of all, that mentioned that the ulcer is present on the lateral border of the tongue, which is the risk. Second point that I mentioned is the my ulcer is present since more than 4 weeks or more than a month, so that is also a risk factor. Okay, although you can do the dental treatment by smoothing that area, but if if I were at that place and I am the dentist and my patient is complaining of these symptoms to me, then I would do the dental treatment and I would refer him straight away to the specialist as well, because in the earlier stages, if we find out any malignancy or any oral cancer, then the prognosis would be better. So if that is the case, we do not need to tell all these things like we are suspecting this or that to the patient, because you did not have done any investigations yet. So and oral cancer is a very big word, so you cannot just use it like just very commonly. So, but on the other hand, the investigation is must in this case. Okay, so you just need to play bit diplomatic in this state, and but just to be more safe, I would prefer to refer the patient straight away on this appointment only, just to get like specialist opinion on that. Okay, so traumatic oral ulcers. Oral ulceration due to trauma is very common and can be associated with trauma. Could happen either through the eating rough, sharp, or any hot food, or it could happen due to sharp, broken teeth, or any dental restoration, or toothbrushing, or any oral prosthesis or orthodontic appliances that patient might have worn or might be wearing, or it could happen due to any chemical burn, such as tooth bleaching products. Okay, so address causes of trauma first. Investigate, like take the history and ask the patient if any of these cause could be related to your patient. Then, including changing oral hygiene practices if toothbrushing is the cause, then you can ask him to use the soft toothbrush, sharpening, smoothing sharp edges of teeth or restoration. If the teeth and restoration is the cause, you can smoothen it down, adjusting prosthesis if that is the cause, or placing wax on the orthodontic appliances. Most traumatic ulcers resolve if you will find out what's the cause of trauma, then it would resolve spontaneously if the cause of the trauma has been adequately addressed. However, if there is any red flag features of oral mucosal disease are present, refer to an appropriate specialist. Okay, so if there is any red flag feature, then you need to refer him. And a saltwater mouthwash is antiseptic and may provide symptomatic relief if temporary pain relief is required. Apply a topical anesthetic or analgesic to the ulcer. So, which is the best analgesic cream or gel that you can prescribe to the patient? You can just learn this concentration and this name. This would be the only gel that you would be prescribing in any case if the patient would come with the pain and he has any lesion. So, which is the gel name? Benzidamine 1% gel, that we read, this thing we read in um, previous topics, that this is a type of NSAID, and this adult who can use this, adult and child 6 years or older. Topic, how they need to apply it topically to the ulcer, 2 to 3 hourly as necessary. Okay, then persistent ulcer. If the ulcer has been there more than 2 weeks, despite addressing the cause of trauma, so you have addressed the cause of trauma, but the ulcer is still there even after the removing the cause, or there is any recurrent ulcers that would require, that would require investigations and referral to an appropriate specialist. And which specialist? Oral medicine specialist. Okay, so we will continue from this topic after ulcer in the next pages. Okay, thank you so much guys for watching my video, and do like, share and subscribe. Thank you so much. I'll see you guys in the next video.